Thank you very, thank you very much for the opportunity to present again. It's a very wonderful Congress that you have here. I'd like to thank Professor Aziz, Professor Hamed, and then also Professor Morsi for having me here. I'm representing Anna as an international ambassador, and are very grateful also to Anna for the opportunity to be here. In regards to this lecture, I have nothing to disclose. Just a little bit about the prevalence of partial rotator cuff tears. It depends on the way that we look at these. If you look at cadaveric studies in patients that are older than 60 years old, the bursal side are about 2.5% prevalent. Articular sided tears are 3.6%, and then intertendinous are about double that, about 7.2%. However, if you look at asymptomatic patients who have been imaged with MRIs, you can see that in the patients that are less than 40 years old, the prevalence is about 4%. Then those patients that are 40 to 60 years old, the prevalence is 24%. And then older than 60 years old, most of those patients will have full thickness rotator cuff. So the partial is only 26%. The etiology of partial rotator cuff tears have been described as sort of two variants, either intrinsic pathology or extrinsic pathology. Intrinsics are genetics, which Dr. Harvey looked at, age, hypoperfusion, synovial fluid. One of my professors told me that this was sort of the waterboarding of the rotator cuff, and then smoking also plays a part in partial rotator cuff tears. Extrinsic pathology was looked at by Dr. Walsh, this posterior superior impingement, and then other authors have described this as microtrauma that has been chronic, and it typically occurs in the same area right at the leading edge of the anterior supraspinatus. The natural history, we've got two good studies, one back in 1994 for Dr. Yamanaka. He looked at 40 patients and followed them with arthrography for a year, and 20% of those partial rotator cuff tears decreased in 1 year. However, 80% had increase in the size. Dr. Koh just recently in 2022 looked at 89 patients and followed them for an average of 23 months. 82% had no progression, 4% had a decrease in the size of their tear, and he found when he substratified the results, he looked at heavy laborers. And also those individuals that had a increased risk of progression were those that had greater than 49% of the width of the rotator cuff that was partially torn. Dr. Ellman, back in 1990 in CORE, this is sort of the seminal research article on the classification of partial rotator cuff tears. He described them obviously like we discussed before, articular-sided, bursal-sided, and then interstitial. However, he went to subclassify that with a grade. Grade 1 is less than 3 millimeters, grade 2 is 3 to 6 millimeters deep, and then grade 3 is greater than 6 millimeters deep. However, I like to think it is very simple, to keep it simple, stupid philosophy, and this is really sort of the way that we've organized this according to the treatment, is that if it's less than 50% of the width or greater than 50% of the width. However, this fails to take into consideration the anterior to posterior dimensions of the tear. I like to think of it, even though it's not been described in the literature, as less than 1 centimeter or greater than 1 centimeter in the anterior to posterior dimension. This is just a simple algorithm that I took from Dr. Strauss in his article in 2011, and it talks about patients' treatment with partial thickness rotator cuff tears. Obviously, the first line of treatment is rehabilitation. If they've failed non-operative management, and then you can really intra-articularly and arthroscopically manage those and determine how thick it is, obviously with your MRI helping you to determine that. Then you can subclassify those less than 50% tear depth. You can either do a debridement without formal acromioplasty or a debridement with formal acromioplasty. And if they're greater than the 50% tear depth, then really there's two ways to do that, either to complete it or to do an in situ or a transtendinous repair. So the non-operative management, those are really reserved for those patients that have Ellman grade 1 or 2, or less than 50% of the tendon is torn, or elderly patients that are not functionally compromised, sedentary patients, and then Ellman at grade 3 I think can be treated if the dimension in the anterior to posterior measurement is less than 1 centimeter. Overhead athletes, we know that I'm much less aggressive with these overhead athletes. Volleyball players, baseball pitchers, anyone that throws something, we know that it's repaired, that they are not going to be able to go back to the support at the same level that they were at. So really, more than 75% is the individuals that I'll treat with the rotator cuff tear repair if they have no concomitant pathology. Operative treatment, really for those grade 3 Ellman patients, if they failed rehabilitation, I always start with rehabilitation first. Dr. Plancher did a very nice job of talking about the risk of infection, and I only do one cortisone injection for these particular patients. A lot of my patients come back very, very happy, but it only lasted for about 6 months. And they want another cortisone shot, but I think that that is definitely not the way to go. So if they've had the standard rehabilitation, a cortisone shot, then I think that they're candidates for an operation. Acute injury, and then also in the United States we have a patient population that's called workers' compensation, and those patients then I'll offer a surgery if they meet the criteria based upon the MRI. And then failure of conservative management in those patients that have a smaller ailment grade 1 or 2. Most patients do fairly well with subacromial decompressions. The debridement and subacromial decompression, Dr. Ellman in his seminal article back in 1990 had 50 patients, and he just did an isolated subacromial decompression with a debridement, and he had 88% good and excellent results. Dr. Cardis looked at his 33 patients that just have an isolated subacromial decompression, did an ultrasound at 2 years, and unfortunately 35% of those patients had progressed, and the constant score was 20 points lower on the effective versus the contralateral. Dr. Cardasco found in his sub-analysis that there was a higher failure rate with a bursal site of tear versus a particular site of tear. So the arthroscopic repair. So there's two ways that we can deal with this. And the first is to complete it to a full thickness tear, which obviously is a lot easier. It's a standard rotator cuff tear after you've completed it. And there's proponents for both of these methodologies. The first, the completion, that Dr. Yamakato in arthroscopy in 2012 has shown that that residual tendon that is still left is very poor quality. And so it's a lot easier to repair. The people that purport that insider repair is better, it says that the residual cuff will help protect the repair. However, if you're treating an articular sided tear, it's definitely much more difficult, and you have to at least penetrate the rotator cuff. So how much damage do you do, and how much rotator cuff do you take down in that particular scenario? But biomechanically, Dr. Mahata has shown it's definitely stronger biomechanically. So the question is really to complete or to not complete the tear. That's the question. Okay, sorry. So the completion is king. There are several articles that just look at just a cohort where they've completed the completed the tear in order to do their repair. Dr. Kamath in Journal of Bone and Joint Surgery in 2009 looked at 42 shoulders. The ASES improved from 46 to 82 at 1 year, and the patient satisfaction level was 93%. However, 37 of the 42 repairs were still intact at the year. Dr. Iyengar in arthroscopy looked at 22 patients, and he followed them for just a little bit longer, 2 years, and found that 82% were still intact at that time frame. And younger patients did better when they substratified the results. Dr. Kim and AJSM in 2014 looked at 43 patients with a year follow-up, and the ASES was 91 and 83, all of which were statistically significant. Bursal-sided tears did better on the constant portion of the patient-reported outcomes, but the re-tear rate was 0% for articular-sided and 10% for bursal-sided, even though the bursal-sided did better on the constant score. The proponents of leaving the tendon alone, Dr. Plachel in 2019 looked at 15-year follow-up of 7 patients that he treated with transosseous repair. He found that the ASES was 92 and the visual analog scale was 0.7. However, he did have a 40% re-tear rate 15 years after performing the procedure. Dr. Castagna looked at his 54 patients, 2-year follow-up, ASES of 90 and VAS of 0.8. Dr. Snyder looked at his patients after 13 years, 93% success rate with healed cuff, and the UCLA and the VAS improved in all patients. So really what we want to know is how they perform head-to-head. Dr. Castagna looked at a level 2 prospective study, minimum 2 years of follow-up, 74 patients, no statistically significant difference in ASES or VAS, and completion had increased strength versus in situ. Dr. Shin looked again at another level 2 prospective study. Average follow-up was a little bit longer, 31 months. Completion group recovered faster. However, they all had the same function, pain, and patient-reported outcomes, but the tendon integrity was higher in the in situ repair. Dr. Kim, another level 2 prospective study, 100 patients this time, significant improvement in ASES constant and VAS, and no difference between the two different cohorts. No difference in the re-tear rate in the articular sided, but the bursal sided had increased risk of re-tear in the completion group. And Dr. Castronici looked at a retrospective study of 94 patients, average 74-month follow-up, no difference in the constant simple shoulder test, but the re-tear rates were a little bit higher because there was a longer follow-up, almost 14% in both groups. Meta-analysis was performed in 2015, 9 studies. All cuffs were more than 50% torn, no difference in ASES, but they did have a higher re-tear rate in the completion group of almost 11%, and in situ was only 4%. So this is the technique that I do for the bursal-sided tear. So basically, look at it arthroscopically, look at it on the bursal side, then I go in and take down basically prepare the tuberosity with a burr, place my anchor, and then with a suture passer, then we'll go in and pass the sutures in for all 4 of the limbs, and then basically just do a transosseous equivalent type of repair. You can either tie the sutures on the the bursal side, or you can just take those to the anchor. It's really dealer's choice. And I also like to do the crimson duvet as well as Dr. Snyder does. So you can see that here. So for time's sake, we'll go to the next one. For the articular side, I'll basically mark the tendon tear with a PDS so that I can find it easily on the bursal side. And then after that, then I will basically go in with this is on the bursal side, the articular side, and then on the bursal side, I'll go in with a liberator after I've removed my PDS and clean that off, and then basically place another anchor. And it's very similar to the way that I just did it. Basically pass the sutures, and this time I did tie those, and then I take them to a lateral anchor in order to provide the transosseous equivalent of repair. So in conclusion, partial rotator cuff tears less than 50% start with rehabilitation. They do very well with subacromial decompression if they fail the rehabilitation. For a partial rotator cuff tear that's greater than 50%, rehab still first, and then complete versus in situ. I think the literature really has not shown too much of a difference. However, there is a higher re-tear rate with completion of a partial tear. So thank you very much. This is the Air Force Falcons. So the Thunderbirds flying across the stadium and the medical hospital there at the Air Force Academy in Colorado. So just another push for those individuals that weren't here for my first speech or for my first talk. I just don't want to talk about the benefits of being an international member. Really the one that I want to really emphasize is the scholarship and grant opportunities. This year we're going to be giving out multiple scholarship opportunities to attend the annual meeting or to attend the OLC course in Chicago of your choice. So thank you very much for this opportunity to present.